Now I would like to introduce Dr. Shahida Parveen. She is working as an associate professor in cancer pain at Kakinada, in charge of cancer pain at Kakinada, and she has various publications in different speaker in national conferences, and her area of interest is pediatric anesthesia, obstetric anesthesia, pain and palliative care. Welcome, Dr. Shahida.
Thank you, madam, for the kind introduction. Now, after the beautiful talks given by our ISA past president Harsur sir and state president Mahesh sir, it's a little challenging for me. I'll try to do my best. So pediatric ambulatory anesthesia, as the word PA says, it is actually a subset of Society for Pediatric Anesthesia. Now, why we need to know about these societies also which are associated, because they're going to help us with the guidelines. And you have our own IAPA, that is Indian Association of Pediatric Anesthesia, being found on 2006. The flow of my talk is going to be based upon what are the benefits for going for daycare surgeries, how you're going to select your patients, what are the different surgeries that you're going to perform, what are the limitations, how is the preoperative optimization and assessment, what are the modified anesthesia techniques you choose, the recovery and discharge, what are the troubleshooting points, teaching and training and further audit. So it is way back 120 years before when James Nicol, a Glasgow surgeon, has done more than 9,000 outpatient operations. Then a decade later, it is a Ralph Waters, hailing from Iowa, who had started his own downtown anesthesia clinic. So why? What is this daycare surgery? Basically, it refers to practice of admitting the children on the day of the surgery after careful selection and preparation for a planned non-emergency surgical procedure and their discharge within 24 hours of that surgery. So what are the benefits and why do you need to go for daycare? You see, children, they are the ideal candidates. They are good in health, they do not have any comorbid conditions, and they like to be back to their familiar surroundings as early as possible. They are afraid of all the needles, pricks, doctors, nurses, strange persons, and the hospital atmosphere. So anxiety, separation from the parents can also be reduced, and there is uninterrupted feeding as well as sleeping pattern and undisturbed schedule of the parents as well, because we know most parents, they come from the villages to get the surgery done at the cost of their livelihood. And we can reduce the chance of nosocomial infections, and the cost of hospitalization when compared to an inpatient procedure is almost reduced by 50%. On the other hand, you have more beds available for the needy individuals and those who have complex procedures to undergo, and modified technique leading to faster recovery and better pain relief methods, ultimately parental satisfaction. So these services can be delivered as a hospital integrated method, wherein you are going to do outpatient surgeries along with that of inpatient surgeries. But you have to specifically concentrate on certain aspects, like there must be a preoperative waiting area and postoperative recovery area. Then hospital-based, wherein you have a separate ambulatory surgical unit which is exclusively going to handle outpatient surgeries, just like we have emergency OTs. And then the freestanding of the autonomic units, like all small nursing homes and all, they do not have much infrastructure, and any untoward complication occurs, they need to refer to a nearby ICU. And then office-based, which is in conjunction with that of the physician's premises. Like most of the NORA procedures, like the gastroenterologist tries to do his procedures within his office base. So when you come to the patient selection criteria, how small a patient can you accept? This is as early as about 44 weeks post-conceptional age, and ex-premature individuals who are greater than 60 weeks post-conceptional age, which is nothing but post-gestational age and chronological age. And then the ASA physical status 1 and 2, and those who are stabilized ASA grade 3 can be accepted. Now, why I have said we cannot take up very small children is because they are more prone to have respiratory adverse events, and especially the apnea. And the children with the congenital syndromes are faced most of the times with the difficult airway, and inborn errors of metabolism, they will not be able to withstand all the fasting protocols. And likewise, the sickle cell disease, there is a lot of problem with the oxygenation and hydration status. And cardiac diseases, especially asymptomatic ASD, VSD, and corrected cardiac lesions can be taken into consideration. And if they have good exercise tolerance, we can also take. Definitely complex cardiac disease, those who have cyanosis and all, we need to avoid. So coming to the social factors, you need to see that their dwelling is within 1 hour from the facility and the parents are responsible. They may not be educated always. Even illiterates are going to be very careful about their children. So you see that any untoward complication like bleeding and all occurs, they must be able to reach the hospital within 1 hour. And if they have a poor housing conditions and if they do not have their own transport or from they are very long off places and there is a history of sudden infant death syndrome in the family, you have to exclude them. So these are a list of the surgeries which can be taken up on a daycare basis. Now, pediatric general surgery, especially the hernia repairs, an excision of the cyst, ganglion, IND procedures, a simple sigmoidoscopies, urological surgeries most commonly done, that cystoscopy, circumcision, and ENT procedures like adenoidectomy and tonsillectomy. Here again, age is very important because when you say adenoidectomy, we would like to prefer only if it is less than 3 years, and we will not be doing tonsillectomy at such less age. And foreign body removals, plastic surgeries, especially otoplasty and cleft lip and certain degrees of cleft palate, orthopedic surgeries. Most of the time we find children coming with history of fall and breaking his humerus, supracondylar fracture. For most, we finish up doing with manual reduction under general anesthesia. And dentistry as well as ophthalmological procedures, especially the strabismus surgeries. Now, what are the surgical limitations? You have to take into consideration only those surgeries which have a duration lasting less than 2 hours, and those which have low hazard of surgical and anesthetic complications with the minimal blood derangements, and those associated with mild to moderate pain. So we will not be going for open cavity surgeries and all, where there will be a huge incisions from almost epiphisternum to pubis and all, where there is a lot of dermatomal involvement leading to increased pain. So, and then patient must be able to accept the oral fluids in the immediate post-operative area. So this flow process is going to start much earlier, almost 5 days to 7 days, almost 1 week earlier, when the patient is first referred to you by a surgeon. You see, first of all, the child is appropriate for the daycare surgery or not. And then day before, again, you check whether the child is healthy, not having any fever and all, and is going to report timely. So as the child appears to you on the day of surgery within the waiting area, you confirm with the fasting status, and then you take the written informed consent. And in the operative area, you try to plan under general anesthesia or regional anesthesia and try to recover the patient in the theatre itself. Sometimes you bypass the PACU and directly you can be sending the patient to the ward. In the post-operative area, again, you do early assessment of the PAD score and then discharge to follow again a week later. In the preoperative assessment, it is not just about the physical finding that is important, it is equally important to prepare the family for this daycare surgery. So the ideal goals would be you can identify who is the anxious child, who is requiring the psychological preparation, patient as well as the parents, who is seeking the parental responsibility, and by this you can minimize the cancellations on the day of the surgery and even avoid the wastage of theatre resources. Ultimately plan your anesthesia, you convey what can be the complications, and then take the written informed consent after shared decision making. So this is a chart which has been taken from the BJ article, which tells you about the perioperative anxiety in the children, because this has been influenced by a lot of factors like the education of the parents, the child who is anxious, having the parents also very anxious, and if the child is being repeatedly subjected to the surgeries, sometimes if it is a very happy atmosphere, the child is going to feel it may not be a problem, but bitter experiences, it becomes all the more problematic. And then you have alternative methods like music, hypnosis, and different distraction techniques, video games and all that we allow them to play with and be comfortable. And easily verbal anesthesia itself may suffice sometimes without any premedication. Because this is one entity which has a lot of role for the perioperative outcome. Intraoperatively, anxious child will require more amount of analgesia anesthesia, and postoperatively they are prone for having emergence delirium and PONV. So these are another two articles, because most of the time parents do have a doubt. They express if this drugs on what the drugs that you're going to give, is it safe for a child developing brain? So this is a gas study and even the PANDA study. Gas is nothing but general anesthesia compared to spinal, and pediatric anesthesia neurodevelopmental assessment trial, as well as the MASK study, that is the myoanesthesia safety in the kids, which has been done in almost 997 children. And these are the studies which definitely give you a lot of reassurance, and especially if it is a single exposure and for very short duration. Of course, we need to have further studies when it is for prolonged procedures and multiple exposures, because that may be having an impact on the developing brain and learning abilities. So the preoperative blood testing as such, if it is an ASA status 1 and 2, we do not require any special test unless there is a significant coagulation history. And definitely for a case of adenotonsillectomy, I would be asking what is the HB, minimum of bleeding time and coagulation time. So coming to the preoperative fasting, it is the 642 rule, and this has got a lot of concerns because increase in the fasting is going to far exceeding 2 hours, that is going to prime the metabolic response, increasing the insulin resistance, thirst as well as emergence delirium, and those children who have undiagnosed enzyme deficiency are prone for hypoglycemic attacks. And added to that, there is a contracture of intravascular blood volume which may lead to sudden collapse of the child once you induce. So the recent guidelines say that we need to minimize the fasting to less than 1 hour and give a carbohydrate preload with a maximum volume of 3 ml. So pre-medicate in the presence of the patient's parents. Though there is no strong evidence for it, it is still followed in our Indian culture. And pharmacologically, giving the midazolam 0.5 mg per kg or a fentanyl lollipop. For the uncooperative children and a resource-limited setting, you still can use ketamine. So monitoring and emergency equipment is none different from that of the routine inpatient surgeries. You need to have the theatre warm with all the gadgets, depending upon the age as well as the weight and everything you need to set up. So the choice of anesthesia most times is said to be the general anesthesia giving sevoflurane. This is the agent of choice because it has a fast induction. Children are going to breathe faster, they have increased alveolar ventilation, and rapid recovery and easy titrability with the inherent neuromuscular blocking agents. You can even use the LMAs and IGELs to avoid the stress of intubation and extubation, and maintain with that of a shorter acting neuromuscular depolarizing neuromuscular agents like atracurium and cisatracurium because of the fast metabolism. Scoline being reserved only for the difficult airways. Low dose rocuronium 0.3 mg per kg allows a tracheal intubation as early as 3 minutes, and you can reverse a child in 20 minutes. So routinely the neuromuscular blockade is reversed with the neostigmine. Now Sugammadex has not yet been FDA approved. And ultimate aim is we need to have a rapid, smooth, atraumatic induction, good operative conditions, and prompt rapid recovery. So if you are planning to give IV induction, total intravenous anesthesia using the propofol, and there is a lot of buzz regarding the TCI pumps, you have the P-diffuser and the Kataria models, which can be used for much less weight individuals, and they can be even used for 1 day, 1 kg old also, the newer pumps. So these have to be considered, especially if the child is having the risk of malignant hypothermia or the PONV and emergence agitation, and if it is a surgery on the airways, and NORA procedures as well as the neuromuscular monitoring. Caudal epidural, the less is more. So low dose of local anesthetic with the adjuvants like that of fentanyl are going to allow you for the rapid recovery without any neuromuscular blockade. Spinal also, this alone has been shown to have a low incidence of postoperative apnea and bradycardia in the form of premature infants when compared to that of GA. And added to that, it has a quick onset with a greater hemodynamic stability, cardiorespiratory stability, and postoperative analgesia. So this is a simple case wherein I had just given glycopyrrolate 1 mg of midazolam in the penile block, and the child was beautifully playing the games and did not even know when the procedure was over. At the end of the procedure, I just inserted a Justin half a suppository. So perioperative fluid management, you follow the holiday cigar regimen, and you try to see that you properly hydrate, because this is going to reduce the chances for the PONV. You give the Hartmann solution 10 to 20 ml per kg of the body weight, and you see that even dextrose has been supplemented. So perioperative analgesia, you use the preoperative period shorter acting opioids like fentanyl. You also use the, if possible, the regional blocks like caudal, epidural, or peripheral nerve blocks, and sometimes simple local anesthetic, local infiltration may suffice, along with the monitored anesthesia care. And use the agents like IV paracetamol. We try to avoid using excess of opioids and dexmedetomidine. And the postoperative period, suppositories or oral paracetamol. So you try to follow the modified Aldrich recovery score. Score greater than 9 is acceptable. And then the post-anesthesia discharge score. This is again modified because here we actually try to see that the vital signs are at least 2 and none of the other parameters must have a score of 0. So ultimately our aim would be to have a child who is awake, well oriented, hydrated, free of pain and vomiting, and legally giving a handout with the proper discharge instructions and the phone number of contact numbers. So you timely advise them to take the oral analgesics and routine antibiotics. So the challenges are when you come across individuals who are having upper respiratory infections and OSA, and emergence delirium and perioperative analgesia and PONV. So the troubleshooters are the OSA, especially a sleep disorder of the breathing, and you accept an individual only if he is little more than 3 years and having apnea-hypopnea index which is around 5 to 15. And obese individuals, you screen if they are having other associated disorders like diabetes and hypertension and rule out any other hormonal disorders. Here our aim is to avoid the sedative premedication, reduce the opioids by 50%, use dexmedetomidine 1 mg per kg followed with that of an infusion at half the dose and continuous SpO2 monitoring. So this is the cold score, that is current signs and symptoms. None or mild symptoms or severe symptoms is scored as 5. Onset of the symptoms, is it greater than 4 weeks or 2 to 4 weeks or less than 2 weeks? Presence of the lung disease, none or mild disease or severe disease like persistent asthmatic episodes, airway devices which have been used like face mask or LMA or endotracheal intubation. Surgery, is it a minor surgery like pressure equalization surgery or surgery on the airway like tonsillectomy, and major surgery wherein like cleft palate or even rigid bronchoscopy. So this is an article which tells you about the validation of the cold score and its prediction in the post-operative respiratory adverse events. The study which has been done in 6,252 children who had 158 had upper respiratory infection. In this, 34 had the perioperative respiratory adverse events like Matisha has told you already, laryngospasm, all this bronchospasm, desaturation, pulmonary edema, all this. So younger age, they found to have a risky factor more. And the logistic regression analysis has shown the cutoff point to be about 12.5, and you find the number of patients who are being shown in the first chart. And in the second, you see that the D as well as O, D which stands for using the airway devices like endotracheal intubation, and O, onset of the symptoms, especially if they are less than 15 days, they are the ones who are prone to have more amount of PRAs. So you follow the algorithm, you judge if it is a mild cough or moderate cough after seeing the risk-benefit analysis, and then you optimize giving the nebulizations and proceed for surgery. If it is severe cold with a fever and malaise, you definitely like to postpone for 2 weeks. And here you have to modify your technique. You try to avoid the endotracheal tube, use the agents which are devoid of respiratory irritation like isoflurane and desflurane, intubation, extubation to be done in the deeper planes with a continuous SpO2 monitoring. Asthmatic individuals also just inquire about when they had the recent episodes. And this is an article actually which is an interpretation from the German Scientific Working Group of Paediatric Anaesthesia, which is going to tell you choose wisely. And this helps you in the decision making when to take the case, what are the do's and what are the don'ts. So emergence delirium, most commonly after using the sevoflurane, instance being higher in the preschool children, you need to rule out if the patient is having the pain. And then you follow modified techniques like TIVA and use the alpha-2 agonistic non-respiratory depressant agents. There is a recently published article which says the effect of intranasal dexmedetomidine administration on emergence agitation is definitely going to soothe the child. So this is a POVOC score. You see that different risk factors like duration of the surgery greater than 30 minutes scored 1, age greater than 3 years is 1, strabismus surgery is scored another 1, and history of PONV within the family is also 1. So as the number of the risk factors are going to increase, the chance for the child to have nausea, vomiting will be more. And then you need to follow this risk stratification. If it is low risk or no risk, you are just going to give one agent, antiemetic agent like either 5-hydroxytryptamine inhibitor or dexamethasone. If it is 2 agents, you give medium risk, you give about 2 agents. If it is a high risk, here apart from giving 2 agents, you would like to even modify your technique like using propofol, which itself has got an antiemetic action. And in the rescue treatment, you try to use drugs other than those that you have used prior, like droperidol or promethazine, dimenhydrinate, and metoclopramide. So these protocols, enhanced recovery after surgery, they have been extensively covered yesterday by Archana madam. So implication of these and applying in this perioperative setup has facilitated more and more number of cases to be taken up on a daycare basis. And the future directions, we will be able to take up more complex procedures in more complex places and more complex patients. But when you take in different new surroundings, you have to see that always all the accepted standards for monitoring of anesthesia and even recovery facilities being available. So to create more awareness regarding this, you need to have a lot of teaching and training, wherein each and everyone can be taken as an individual module of patient selection, effective analgesia, PONV, the requirements for the safe discharge, and post-op, what you need to follow. And auditing, especially each and every component has definitely impact on the outcome. If the booking process of preoperative preparation has been problematic, the chance for the patient to get patient surgery to be cancelled on the day will be more. If the admission process is delayed, theatre start times also will be delayed. If the anesthesia quality that you give has been compromised, then unplanned, unanticipated admission, sometimes we give overdose of opioids, so they are the ones who will be having more of PONV, and we need to admit such children. So recovery and the post-operative discharge criteria, if you do not properly convey them, the chances for you to be contacted out of the regular hours, calls in the midnight, these and all are going to be more. And effectively, we need to have an auditing to improve the quality and efficiency improvements. To conclude, so this is actually a teamwork, and we need to have careful selection of the cases with a meticulous preoperative assessment, which is a must for the successful ambulatory anesthesia. Judicious use of the recent rapid-acting anesthetic agents, well-defined systematic approach and organization will improve the success rate. Thank you.